Welcome. My name is Lydia Lanman, and I'm the Senior Global Access Policy Leader at Roche. I lead our global policy efforts in Alzheimer's disease. I'd like to welcome you today to Roche's sponsored symposium, Lessons from COVID-19 for Alzheimer's Disease Health System Readiness. The ability of a person living with Alzheimer's disease to access new Alzheimer's disease diagnostics or treatment will depend largely on whether the healthcare system is ready to provide timely detection, diagnosis, treatment, and care. What we do know is that today, healthcare systems are ill-prepared to meet the current and future needs of Alzheimer's disease. The COVID-19 pandemic has made this reality more apparent than ever. The pandemic has had significant devastating impact on people living with Alzheimer's disease and their families. At the same time, we have seen a tremendous amount of innovation in how and where care is provided during a public health crisis. And while we are still living through the pandemic, there are already a number of lessons from COVID-19 that we can apply to preparing healthcare systems for a future in Alzheimer's disease. Today's symposium will focus on understanding the current challenges and opportunities in preparing health systems for AD. Our expert panel will share their perspectives on the lessons from COVID-19 that we can use to ensure health systems are ready and people living with Alzheimer's disease can benefit from new innovations when they become available. I would first like to introduce Dr. Soeren Mattke. Dr. Mattke is a research professor of economics at the University of Southern California, Dornsife College of Letters, Arts, and Sciences, and the director of the Center for Improving Chronic Illness Care. Soeren will share some of the work he has done in examining healthcare systems in Alzheimer's disease, including findings from some recent work published earlier this year regarding health systems in Europe.
So thank you, Lydia. It's a pleasure to be here today to talk to you about our analysis of the implications of Alzheimer's treatment for the organization of medical practices in the EU 5 countries. So why am I worried about health system preparedness? Alzheimer's disease is one of the last population-level conditions for which we do not have a disease-modifying treatment at the moment. So it would be an enormous breakthrough if we actually did get to a treatment as early as next March. But there's the problem that we have this large pool of prevalent cases that need to be diagnosed and treated when the treatment first becomes available, and that could easily overwhelm health system capacity. The reason why this is so complicated is that we need to identify the condition in its early stages so that we can prevent the progression to manifest dementia. And while prevention sounds easy, it is in this case a very complex diagnostic process that looks more like advanced oncology care than anything else that you might associate it with prevention. So unless we address the capacity constraints in a timely manner, we may see millions of people living with early stage Alzheimer's disease today to progress to manifest dementia on the wait list. And COVID-19 has painfully illustrated the fact that it is extremely hard to prepare for unexpected surges in demand unless you start the process very early. In preparation for this disease-modifying treatment, we have a research program with 3 main components. We use simulation models to estimate whether there are any quantitative bottlenecks in treatments, like access to specialists, to biomarker testing, to infusion delivery, and we have done this for several countries so far. In the next stream of research, we go a little deeper beyond capacity because obviously healthcare is more than numbers. We look at the institutional obstacles to expanding capacity, such as coverage, incentives, regulation, capabilities, and that work has also been completed for several countries and others are in progress. And in the last work stream, we are actually going from quantifying the problem to solving it. So we look at better diagnostic technology that will help us overcome these bottlenecks and also improved care models that help us to stretch scarce specialist capacity further. A brief overview of the capacity simulation work. We use a highly stylized clinical journey for patients where we start with early stage Alzheimer's disease, i.e. no cognitive impairment, but early signs of the disease. And those patients might present most likely in primary care settings for an initial evaluation. If the primary care physician detects early signs of the disease, i.e. mild cognitive impairment, he or she would refer to further evaluation to specialists. And there it is the point where we run into these capacity constraints. In most countries, there are not enough dementia specialists to see these patients and evaluate whether the brief cognitive assessment in the primary care office actually points to early stage Alzheimer's disease. We also have a constraint in terms of verifying that the cognitive decline is due to Alzheimer's disease as opposed to other etiologies with PET scanners or CSF testing. And then lastly, some of these treatments are actually infusion delivery, and with the large number of patients, we would have to have enough infusion centers to deliver the treatment in a timely manner. Then the idea is once we overcome these constraints, the treatment would reduce the risk of transition from early stage disease to a later stage where treatments are no longer effective. What we find is that there are substantial wait times, particularly because of a lack of dementia specialists. And these wait times vary quite a bit between countries. You can see here Canada will have quite long wait times initially, and then the wait times actually decline very slowly because they not only have a problem with lack of specialists, but also limited capacity to do biomarker testing. You can see a different situation in the US, which is this orange line, which has a relatively high wait time initially when the dementia specialist constraint is effective, but the wait times decline pretty fast because biomarker testing is really not a big problem. Conversely, you see other countries like Germany and Italy here, gray and dark red, that have very short wait times because in those countries, psychiatrists, which are a much larger specialty, are involved in dementia care, so they can clear the wait list in theory much faster than other countries. So now to the policy work. What we wanted to do is identify potential risks to access along our expected patient care pathway. So coverage, capacity, and capability, and then also point out solutions at any of these steps. A particular attraction of this multi-country work is that we can identify best practices and lessons learned from other countries to point to low-cost, no-cost interventions that can help improve access. And we're also looking into feasibility of these solutions at a very high level. So we're not trying to do a formal feasibility study, but just assessing whether this is at all realistic. So here's the analytic framework that we are using. Again, we have a patient journey, this time a bit more granular than what we used for the capacity modeling. So going from initial screening or case finding, cognitive testing, formal diagnosis of Alzheimer's with biomarkers, then decision to treat, treatment delivery, and also monitoring, which shouldn't be underestimated. And for each of these steps, we ask whether the services that are contained in this little chevron are covered, and also whether the coverage is adequate to ensure delivery, and those two things are not necessarily the same in memory care. We look again a little bit into capacity, and then also, given what we know about coverage and incentives, whether the capacity would actually be devoted to the respective care step. And then we want to know whether the providers are trained and qualified and have the right tools and technology to deliver these services along the patient journey. Okay, so what we find is that there are common challenges in all the countries that we have analyzed so far. Most jurisdictions have a dementia plan, but it is mostly a declaration of intent. There's rarely ever funding attached to the dementia plan that would make all these ideas and proposals reality. What's also important is that coverage of the services along the patient journey remains inconsistent. In particular, in most countries, confirmatory biomarker testing with CSF analysis or PET scanning is not covered. which makes some sense at the moment because the exact diagnosis of the etiology has limited therapeutic consequences. But of course, if we have a disease-modifying treatment, it is essential that we confirm the presence of the Alzheimer's pathology. And we have to keep in mind that we can assume but cannot take for granted that health systems will start covering the services when the treatment becomes available. What we also see is there is absorptive capacity in many countries, but that doesn't necessarily mean that the capacity will also be devoted to memory care if the treatment becomes available. One reason is, for example, that many countries, especially in Europe, operate under actual or functional global budgets, which means providers are not making more money if they work harder, and therefore the incentive isn't there to scale up patient volume. And then there's also a problem that the investment decisions, again, in particular in government-run or regulated countries, into human or physical capacity take actually a long time. So adding new positions to a memory clinic, adding a PET scanner can take years and may not happen in time to take care of these patients. And then we really have a capability problem because at the moment, memory care is sort of a stepchild given the limited therapeutic options that we have. So primary care clinicians remain reluctant to even look for cognitive decline. On the one hand, they find it incompatible with their workflows. With your typical 15-minute office visit, it is hard to do cognitive assessment, talk maybe to even family members to get a sense of how much of an impairment comes with the cognitive assessment. So they are not really trained and also believe that the therapeutic consequences of making the diagnosis, and in particular an accurate diagnosis, are limited. It's also a problem in the memory clinics that are specializing in cognitive decline because at the moment they mostly focus on quantifying the deficits that patients have. They are really not equipped to handle the medicalized nature of a disease-modifying treatment with biomarker testing like spinal taps, PET scanners, infusion delivery. So they would have to be transformed to actually accommodate such services. And then we see some arcane gaps in technical functions like neuroradiology. So even if a country has enough MRI scanners to do the monitoring post-treatment initiation, there may not be enough experts to read all these MRIs just because of the high volume of scans that will appear. There are, however, encouraging examples. It's not that countries have not recognized the challenge of dementia and also the challenge of disease-modifying treatment. So you can see that there are interventions in play that can actually help us greatly. For instance, in the UK, we see that there's an accreditation scheme that standardizes memory services. So they try to ensure that a certain service level is always provided, and they also have a dementia diagnosis rate as a performance measure for general practitioners. So basically they hold them accountable for finding patients roughly at a rate at which the age structure of their panel would suggest we find dementia cases. France, for example, has instituted a national network of memory clinics, and in a particularly interesting setup, they deliberately divided it into centers for routine care and research centers like regional centers that also currently operate the clinical trials, and they can become the living laboratory to learn about treatment delivery. An interesting fact about France is that they have embedded a right to know about cognitive decline in their national dementia strategy, arguing that we shouldn't make it the business of clinicians to decide what people living with Alzheimer's disease ought to know. We should have the right for patients, like for a cancer patient, to know the state of their disease and the prognosis and the exact diagnosis. What you see in Spain is a similar approach, centers of excellence to focus resources on limited regional centers to provide the complex services. And they also have a standing expert group that looks into regional preparedness and gives recommendations to regional governments how to improve memory care. What you have seen in Germany is a trend to take complex conditions out of the routine reimbursement system that is heavily fee-for-service, but with global budget for practices, and create integrated payment contracts that remove some of the disincentives to scale up services. They also started covering a comprehensive geriatric assessment, explicitly including memory assessment into the benefits package. In Italy, they launched a very interesting national program to identify MCI patients at an early stage of the disease and track their progression to identify who might be at risk for fast progression, i.e. who would become a priority candidate for treatment if resources were constrained. And similarly, like in other countries, they have a national expert group and observatory to track progress in memory care and also then later in disease-modifying treatment and collect and report data. So here are some of the solutions that came up in our research. Given what I said earlier about the limited capacity of dementia specialists, we need to move more of the early diagnosis into primary care. They are the entry point into the healthcare system and they're less capacity constrained than specialists. And what I said earlier, the problem is that at the moment, many primary care physicians do not see it as their business to even inquire about cognitive decline or to respond to subjective memory complaints. This, of course, does entail the risk of a delayed diagnosis, potentially beyond a treatable state. And it's complex to address this reluctance, but it should be possible. There's largely an issue with training and knowledge because many primary care physicians have limited geriatric training in their post-medical education. And then there are is the reluctance to address the disease because of the perceived lack of consequences. And we have the problem of workflow compatible tools, so things that actually fit into the dense work schedule in primary care, and also the incentives to reward them for the extra time that it would take to follow up on a subjective memory complaint. So we looked into what tools would be suitable for primary care settings. We published the report last year in the Journal of the American Board of Family Medicine. And the most promising tool that came out of this research is blood-based biomarkers. So a blood test to verify that a patient has the presence of Alzheimer's pathology. We recently analyzed the impact of this blood test in the US to see how much it could actually improve access to care. So the results are here on this graph. On the y-axis, you see the number of specialist visits that we would need in the US to evaluate all the patients that would be referred from primary care. The dotted line here, the dashed line here, shows you the number of available specialist visits in the US in each year. And then the blue line gives you the results of how many specialist visits we would need if patients got referred based on a brief cognitive evaluation like a mini-mental or MoCA only. So you can see that the expected demand would greatly exceed the supply of specialists over many, many years. And the reason is that we are referring a lot of patients who may have cognitive decline, but may have cognitive decline due to other causes. Conversely, if you add the blood test after a positive mini-mental, you refer a lot fewer patients to specialists, and the number of required specialist visits drops pretty quickly below the available supply. So an easy technological solution that can have great impacts on patient access to treatment. We also need better care models. If we move more of the responsibility into primary care services, we need to rearrange their care pathways, their staffing, their organization, also their payment, to allow for task shifting, for them to hire a memory nurse, maybe a social worker. And there are several care models around the world that can be blueprints how primary care could rearrange their practice patterns. And then we also need to have rewards for high-value memory care. So we need performance measures, ideally tied to value-based payments, to create an incentives for primary care physicians to devote more of their time to identifying and diagnosing patients. This isn't all a problem about primary care. Specialty care will also have to evolve. From what I said earlier, most memory clinics to date focus on diagnosis and quantification of the decline and the functional consequences, and then organize referral for social services and counseling. The medicalized nature of these next generation memory clinics will require a substantial rearrangement of these clinics. So to go from care to cure means either changing the way that these practices look and operate, or co-locating them with acute care facilities that have the required capabilities. This medicalized approach also needs scale. It is not particularly efficient to have, say, a procedure room for lumbar punctures if this is a single physician practice who does maybe 10 lumbar punctures a month. So we need larger practices, we need more ability to task shift, a greater variety of clinicians to handle the tasks involved in diagnosis and treatment. And this, of course, calls for a centers of excellence approach, because it is easier to concentrate these capabilities in regional centers than in small local centers. We also need to be sure that the diagnostic pathway is standardized so that we have a streamlined process for patients to get diagnosed. And that can be done like in France with central planning, or in the UK with an accreditation model. We need to rethink payment for memory care. The treatment will be expensive given all the investments into its development, and there's a lot of patients that will require the treatment. So there is going to be substantial budget impact that will make many policymakers nervous. So we have to find ways to soften the blow, to stretch the immediate impact into the future, for instance, with deferred payment models for these treatments, or potentially with outcome-based treatments that have a hefty bonus on actually avoiding progression to dementia and nursing home admission in the long run. We probably need to go to bundled payment to give clinicians greater flexibility and don't tie them as closely to fee-for-service schedules as they are currently today. And we need to pair these bundled payment models, as always, with quality measures to make sure that efficient treatment doesn't come at the cost of quality to patients. So allow me to summarize. The preparation for disease-modifying treatment is not an easy task. Many stakeholders are involved. We have tight finances given all the competing requirements for governments. And we know that we are running out of time if indeed the treatment becomes available as early as next March. So what do we need to do? We have to spend smarter, not necessarily more, and our analysis has pointed to a few opportunities for low-cost, no-cost ideas. COVID has also taught us that we need to get started early. It's extremely difficult to prepare a health system quickly for something that it has never accomplished. So we must get to work really soon. And we owe this action to our parents and grandparents who might get affected by the disease in the near future, but also to our children, because we need to leave them with a sustainable social protection scheme that is under severe threat from the tsunami of dementia that we are projecting.
Thanks, Soeren. I'd like to now introduce our other panelists. Dr. Eva Holmerova is the board chair of Alzheimer's Europe. She is also the CEO of the Center of Gerontology in Prague, as well as the Vice Dean for International Relations in the Faculty of Humanities at Charles University. Next is Chris Lynch. Chris is the Deputy CEO and Director of Policy, Communications and Publications at Alzheimer's Disease International. Dr. Maria Soto is the head of the Alzheimer's Acute Care Clinic at the University Hospital in Toulouse. Dr. Martin Traber is the Global Medical Lead for Alzheimer's Disease at Roche. So we'll get started. So we heard from Soeren that there are a number of health system challenges that would impact the ability of someone living with Alzheimer's disease to get a timely and accurate diagnosis and potentially access to a new treatment for their Alzheimer's. Sometimes it's really difficult to know kind of where to start and which challenges to address first. So this first, I'd like to kind of, Eva, for you to weigh in from your perspective. If you could address only one thing and one challenge, what would you focus on today to ensure healthcare systems can be ready in the future?
So I think that there is one overarching issue or overarching topic that needs to be addressed and can help in all fields, because we speak about diagnosis and treatment and post-diagnostic support and psychosocial intervention, etc., etc. And I think that one crucial thing is the education of staff on all levels, not the top specialists, of course not, but providing enough information to general public, education of people themselves in these issues, and first of all, education of primary care staff. I mean, general practitioners and nurses and also people working in social services to be more sensitive towards dementia, towards first signs, symptoms, and to be able to advise them where to look for the support and care and diagnosis and treatment.
Great, thanks. It all starts at the beginning, doesn't it? Now, Maria, I'd love to get your perspective on the same kind of tough question. As a clinician seeing patients every day, where would you kind of focus your attention now in terms of health system challenges?
So this is a very tough question, because I think like the main challenge today, and as it was said before, is to construct a real pathway care from detecting to diagnosing to treating to caring. And I think the most important thing is to coordinate all that. And training, as Iva just said, I think it's a main issue, but just not training in primary care. I think we need also to train general population to inform that, you know, sample memory loss or memory complaint, even if it is an older person, it's just normal, it's just life. So I think we have to begin also from the general population and to go to primary care. And primary care, as just have been said, it's to provide training in more easy, faster, short cognitive tests. Not only done by GP, because we know how busy they are, but also maybe to train like nurses in order to do this screening in massive population primary care. And then also this coordination between primary care and between specialists, memory clinics, which is I think it's a big challenge today. And we see in clinical practice every day that there is a huge wall between GP and between what happens in memory consultation. And that's why I think that's one of the main reasons that today we diagnose so late. It's too late when we diagnose, and we've seen all these mini-mental mini-score at the moment of diagnosis. We are at moderate, even severe stages of the disease when we diagnose. So I think it's a big challenge, this, you know, destroy this big wall between GP, between primary care and between us, the specialists in memory consultation.
Yeah, I think you raise a really good point. There's so much connection, right? So kind of this early training that Eva spoke of, and then at the primary care level, but then also how that interaction happens at the specialist, for sure. And Chris, so you at ADI have a view of all of the challenges and the opportunities across the entire world with respect to Alzheimer's disease and some of the pieces particularly that Soeren highlighted. From your perspective, where would you guys suggest we start?
Thanks, Lydia. I'm going to take it back or up a level if I can in terms of my thoughts on this question, and it ties in very nicely with the WHO's Global Action Plan on Dementia, and effectively it's around awareness in the first place, and some of the stigma and the fear that feeds into delays for people coming forward. And I genuinely think that there is a fear there. It's based on a lack of understanding that anything can be done. And it's almost a supply and demand question as well. You know, effectively by removing some of those fears and those stigmas to coming forward for diagnosis and for treatment, you actually create the demand for diagnosis and treatment, and then the healthcare system has to adjust to that as well. I think when we did our global survey last year, we realized that stigma was still a huge barrier to people coming forward, and those fears are born out of a fear of loss of identity, of change, home admission, etc. But underpinning that then with the medical model that effectively, you know, there are treatments and supports available, helps reduce that, and in itself then creates the demand. I think something that came out quite strongly from that particular survey was that there's still some issues around awareness, even within the healthcare system itself, in terms of a belief in what can be done. But I also think that one of the holy grail options here is that when we do get this diagnosis breakthrough, a blood biomarker breakthrough, quick, non-invasive, painless, accurate test, followed by treatments, I genuinely think that will remove a huge element of the stigma and the fear, and then effectively drive health system change as well.
Great, thanks a lot, Chris. And Martin, in your role at Roche, I think we're constantly thinking about how do we bring new diagnostic tools as well as treatments to people living with Alzheimer's disease. What's your perspective on this? Where would you focus the attention?
Yeah, thank you for the question, Lydia. I guess very much we look to changing the paradigm in terms of how people get diagnosed and then eventually treated with disease-modifying treatment once they become available, which we hope is going to happen in the near future. So the paradigm shift we're looking for is actually being able to identify the right patients at the right time for then access to disease-modifying treatment. So it's ensuring that in the workflow, in the diagnostic workup, biomarkers play an important role. And that these biomarkers that are already available, at least in Europe, also the CSF biomarkers, they get adopted, that the awareness, the training and education needed also to apply them gets actually really utilized, and we make every effort to make them broadly accessible. And that starts with the AD specialists already today. And the CSF biomarker testing will be needed to allow access then to disease-modifying treatments of the first generation, the anti-amyloid beta. So that we believe is a critical piece, and actually adopting that practice of diagnosing the patients with the biomarkers today already, before we get eventually in the blood-based biomarkers, is of importance.
Great, thanks so much, Martin. Okay, that rounds out our first question. Wonderful. Was there anyone that wanted to kind of add anything?
Probably just one thought, if I don't know, for the group, not sure if that resonates with everyone, but we hear different aspects what matter. And what we know is that the diagnostic pathway and then the care pathway for people living with Alzheimer's disease is quite complex. And looking at it like a chain, every chain link really matters. And I think we're looking of creating really, really strong chain links. And I guess what we hear also from you, Soeren, and the research undertaken is that there's not a one link that is missing or weak. It actually takes all of the chain links, right, to line up and work and be really tight. So I think we're trying to raise really the quality of care, the quality of training and education, the use of the biomarkers, everything really, so that, again, all of these links become stronger.
Great, thanks a lot, Martin.
I agree with what everybody said. I think as I heard you speak, I think these comments highlight one more general health system design question, and that is that primary care in many countries tends to be overwhelmingly very small practices like onesies, twosies, and we may have to think that this structure of primary care is no longer appropriate, not just because of Alzheimer's disease, but also for many complex chronic conditions of the elderly, in that you are probably better off with like the UK type practices, the GPs that have larger practices with more support staff, more linkages to social services, so that it is sort of a one-stop shop for people with complex chronic conditions, as opposed to these sort of entry points where you have to have a lot of referrals to actually get your imaging done, your blood drawn, and your diagnosis, and then your relation to social support. And I think going forward, this may be sort of the catalyst that helps countries to rethink primary care and build generally more effective and efficient models of primary care delivery.
And I would like to add one idea that I was thinking about while we were discussing, and I think that besides the great news from a maybe, hopefully, new disease-modifying treatment coming, I think that, well, first of all, we're not ready, and we really need to be ready with all, all the points that we just all said. But I think that besides disease-modifying treatment, which only very mild patients are going to receive, because this treatment, we know that they are efficient with, and they work in this population of very mild stage of the disease. Anyway, we really need to be ready, and we really need to enhance this pathway, this model care, because still people won't be diagnosed earlier, and we will have patients and moderate and severe stage of the disease. And anyway, we need this to improve this model care, to to anticipate and to prevent all these dramatic complications of the disease, falls, behavioral and psychological symptoms, all the hospitalization, of course, all the caregivers with the high burden, etc. So I think it's besides the disease-modified treatment, anyway, it's something that we really need to change our system, and it's a challenge that every single country should really think about it.
Great. Thanks, Maria. Eva, I have a question to ask you. You're from the Czech Republic. Are there some examples from Central or kind of Eastern Europe that are showing some promise in terms of addressing some of these health system challenges?
Yes, there are some good practice examples, both in care pathways, in community care provision, but especially, and I think it is the main focus of Central and Eastern European countries, on high quality and excellent medicine. So it's much more popular than boring but very important community services, and therefore I think that and they are very, very supported within teaching hospitals, etc. So I think that there are many examples of excellent workplaces and centers and university hospitals in many of these countries. If I can name, for instance, yes, Czech Republic as well, and also, of course, Poland, Hungary, Croatia, Slovenia. So I think there are potential good points for collaboration there.
Yeah, thanks for sharing that. It sounds like there's maybe some new countries that Soeren and his team at USC can take on in their next round of reviews. So thank you for that. The next question is dealing with the second question, really talking about the lessons from COVID-19. So COVID-19 has really exposed the capacity challenges of health systems when faced with an unplanned public health crisis. What do you see as the most important lessons from COVID-19 that can help us support our thinking, our planning, and the actions that we can take with respect to ensuring that healthcare systems are ready for a future with Alzheimer's disease modifying therapies? And Soeren, I'd like to maybe weigh in first.
Thank you, Lydia. I think we did learn a lot from COVID, like you said, from what happens if we don't plan ahead. We also learned that healthcare systems are remarkably adaptable if there's a true crisis. We saw, for instance, rapid adoption of telecare, which was always a big issue and people thought it could never work. All of a sudden it became commonplace because, yeah, it may not be as good as an in-person visit, but it is surely better than leaving somebody to their own devices. So I think we have seen that practice patterns, practice models, technology can change very quickly if there's enough will and enough pressure. And I have hope that we can create sort of that same sense of urgency for a disease-modifying treatment.
Great, thanks, Soeren. And Chris, I'd pose the same question to you. I know you and Paula Barberino did a series of really great webinars really early in the COVID-19 crisis, trying to really extract some of the lessons from Asia, but as well as kind of across other countries. What do you see as the best and kind of lessons that we should take from COVID-19?
Thanks, Lydia. It's a super question, and referring back to presentation where he talks about advanced planning, and I just think we cannot undervalue the need for better advanced planning and to learn some of the lessons around COVID-19 to prevent diagnostic interruption and also treatment to ensure access to specialists and tests. And something that comes back to me constantly during this period is that our constituencies overlap greatly here. Age is obviously the biggest risk factor for dementia, and older people are most at risk of COVID-19. So there's a real poignancy to it. And I think there's an issue and a challenge around data. I know we are still yet to start to see data on something like diagnostic interruption, and we're starting to see some emerging data around dementia mortality. But evidently, there's an urgency, and again, Soeren mentioned this urgency. Delays through something like a pandemic and interruption can lead to disease progression, limiting the effectiveness of treatment and intervention when we do get to that point. So I think more than anything, it's vital that we have government and health and care system preparedness for future pandemics, and genuinely let's learn the lessons, because there have been some incredible reactions and adaptations, I think, through health and care systems globally that we can share and showcase amongst the community.
Great, thanks so much, Chris. And Eva, Alzheimer's Europe has actually done a lot of work around COVID-19, talking about the impact that has had on people living with Alzheimer's disease and their families, the impact on getting a timely diagnosis and access to care. From your perspective, what are some of those lessons from COVID-19 that some of your kind of colleagues and members in Alzheimer's Europe are really kind of focusing on to apply to Alzheimer's preparedness?
Thank you for this question, and thank you for the focusing of this question of Alzheimer Europe. It is what I wanted to present at first, and then I would like to mention also my position as a Czech physician on long-term care. So let us start with Alzheimer Europe. I think our experience is experience of mutual support, help, and collaboration, which I feel really very, very privileged to be a current chair of Alzheimer Europe, because I really appreciate this collaborative way of doing things. So we had several meetings just from the beginning of the pandemic, and produced not only annual reports and ethics documents as usually every year, but immediately we just discussed the very burning issue of resource allocations in intensive care, because we felt that it was very, very important. And many organizations immediately translated this material into their national languages, which is such a proof of importance of this material. The second one was also in collaboration on well-being of people with dementia. and their family caregivers with, I think, also very important recommendations, not only to Alzheimer's societies, but also to caregivers, professional caregivers, family caregivers, and last but not least, governments, because their input is, of course, very important. And last paper was on research, addressed how to modify research in current situation that is very difficult and sometimes very unfavorable to research and researchers. And we just argue that it is necessary to modify and to be flexible, not only for researchers but also for funding agencies. So I think it's these three materials that were developed just lately and during the COVID pandemic.
That's great.
And if you allow me to continue, not very long, but to give you a view of a physician, of geriatrician who works in the field, and I have some experience. And just last week there was a European geriatric conference, and we had a meeting on long-term care. So we just agreed that huge problems occurred, especially in long-term care provision, and that models of skilled, qualified long-term care, which is led by a nurse and physicians, appeared maybe, but we have no data, of course, but it looks that they were able to protect themselves better against infection compared to these quite social care models that are common in some European countries. So it was our first discussion and experience that long-term care is a huge problem in COVID pandemics, and not only in COVID pandemics.
Thanks a lot, Eva. And Martin, to you, Eva mentioned one paper that Alzheimer's Europe put out around the impact on clinical trials and research, particularly during a pandemic. From your perspective, are there some lessons that I think we learned, because we are running a number of clinical trials at Roche during this time, and any other kind of lessons from COVID-19 that you think we can apply to AD health system readiness?
Yeah, thank you, Lydia, for the question. I guess there are a couple there. I mean, first of all, to acknowledge that people living with Alzheimer's disease are an especially vulnerable population, and directly we've seen the impacts from COVID-19 in terms of their possibility and ability to actually get the care that they should deserve and usually get. Obviously, the clinical trials are a very controlled setting, and an extra effort has been undertaken by investigators and site staff to make sure that the integrity of clinical trials could be maintained. I mean, the reality of the clinical care routine looks very different, right? And there we've seen the impact of COVID-19 for people who then have had difficulties in accessing specialty care. I guess a key lesson we learned from COVID-19 also is to be able to have a compass in hand, to be able to navigate a situation with a lot of uncertainty and trying to reduce the uncertainty. I guess in the case of COVID-19, we're looking at testing and evolving the tests also that we have to understand what happens actually from an epidemiological standpoint. And there probably is an analogy, if you may, to Alzheimer's disease. Being able to do that testing timely and at scale also is absolutely critical. And that, I guess, brings us then also back to the importance of biomarker-led diagnosis and care management of Alzheimer's disease in the area before disease-modifying treatments, but then also as disease-modifying treatments become available. I guess the third point also is being able to have flexibility, flexible care models also. For instance, to receive the consultations and the care at home also, and then eventually also again looking at disease-modifying treatment to have the flexibility to administer also disease-modifying treatment at home definitely is a preference and a need also.
Great, thanks, Martin. And Maria, you were right on the front lines running a clinic. Would love to hear from you some of your key lessons from COVID-19 and understanding we're still going through it, right? And we're heading into the second wave. So what kinds of things can we apply to preparing the healthcare system for Alzheimer's?
Thank you, Lydia. So in my opinion, the most important lesson learned is to avoid further interruption of all access to patients and caregivers, which has been responsible for dramatic collateral side effects from COVID-19. And I think we shouldn't do that anymore. And I can say that, as you said, from my clinician point of view, from what I have observed and experienced during the 2.5 months of lockdown in the spring, and we're all unplanned ambulatory outpatient consultation or even planned hospitalization, but also all the activities provided to aid patients and caregivers, such as daycare or professional at home, such as psychotherapists, logotherapists, or even those professionals working also in nursing homes, or AD mobile teams, and all support, all care, all these activities were cancelled because of COVID-19. And this interrupted care follow-up had a tremendous negative impact on both AD patients and their caregivers. And when during summer, and even September, even right now, when we're getting back to this normal follow-up, we can see that the negative impact in patient worsening disease in terms of cognitive, physical decline, but also in behavioral and psychological disturbance symptoms. But also negative impact on caregivers who were isolated and were facing by themselves this disease worsening of their spouse or parents, resulting in increasing caregiver burden and depression and so on. So I think that for the first time, if we really need to do another lockdown or diminish all these planned care services, we should really organize in another way, because that's been like that had a very dramatic impact in patients and caregivers. Maybe based on new technologies as telehealth development.
Great, thanks, Maria. Any other comments in terms of kind of lessons learned and things that we wanted to highlight? I think you've heard about the need for advanced planning, the need to really look at the caregivers. I think in terms of if you're isolated, but also touching on some of the opportunities. Yeah, just open it up to the floor.
There might be one thing, Lydia, which might be relevant for our conversation here today also, and the challenges of preparing healthcare system for Alzheimer's disease is also, we were looking to trying to coordinate the efforts globally, right? But there's no such thing like just a global situation. Everything is very local, and the actions, the implications, everything happens at the local level. But I guess what we could look also for is try to learn as fast as possible from best practices, from insights, from research, from solutions also, and to transport them into other places also, into other healthcare systems. That might be an interesting aspect also to discuss here.
Yeah, and that's a really great segue, Martin. I think you started to really kind of go where I think I wanted my last question for the panelists to be. And really it's on, we've seen a number of challenges. We continue to see the number of challenges and the devastating impact it's had, particularly on people living with Alzheimer's disease and their families. But I think there's also been a lot of hope and a lot of innovation that have never seen in, I think, probably all of our lifetime in terms of healthcare system. In thinking about it, what would you see as the kind of like the biggest innovation, or like the most useful innovation that we've seen in the last 6.5, 7 months that could really kind of move the marker, really change how things look for Alzheimer, for treating Alzheimer's, detecting Alzheimer's, and addressing the needs of patients in the future. And I don't know, Martin, if you want to kind of kick us off here, and then we'll get some thoughts of the other panelists.
Yeah, sure. I'm happy to, Lydia. Thank you. I guess we are very fascinated also with what we see in terms of innovation in the digital health space. There is a lot of innovation happening. We see solutions that help enable patients, caregivers to manage the situation and their disease. And this spans from access to information, to educate, but then definitely also to navigate the care pathway, where to get a diagnostic testing, for instance, where to look for multidisciplinary care later on. So that is very promising. And equally also digital health solutions for healthcare professionals are very promising also. Again, we're not just looking at apps, but also integrated solutions that then really help overcome some of the challenges that also the research by Soeren actually could help to be addressed through such solutions. And that, interestingly enough, is not only for diagnostic solutions, but then again throughout the care pathway, up to including the monitoring and the management, also beyond then actually the earlier stages of Alzheimer's disease.
Thanks, Martin. Chris, where would you kind of want to highlight in terms of one of the innovations come out of COVID, something that could have really useful applications in Alzheimer's disease?
Sure, thanks, Lydia. I think early on we had a lot of rhetoric from politicians and using the analogy of comparing the pandemic period to wartime periods, and I was kind of took a natural dislike to that analogy. But when I started to think about it more, I thought, during those periods of war, often we adapt and invent and innovate at a much faster rate than we would during the normal course of events. And I think the pandemic has resulted in that, and particularly to pick up on what Martin had talked about, which is this virtual support. And this has come through really strongly, and we ran a series of global webinars this year, and without fail, pretty much every country that we spoke to had to shut down their face-to-face supports, whether that was for post-diagnostic support or any form of treatment or access to GPs. And I think the virtual nature of some of the innovation has really come to the fore, and I'd certainly like to see it further develop, but as a temporary alternative as well. And we know it can also tackle additional challenges around isolation and mental health, as well as maintaining health and care appointments. I think really simple things like FaceTime and Zoom, not only have they maintained connections, but they've become a kind of a therapeutic virtual hug. And I think that as a society, as a world, we have also had to adapt and learn how to use them as well. And it becomes a cyclical thing. It will feed for further innovation in that field. But genuinely, hand on heart, our return to face-to-face support, treatment and care is absolutely top priority.
Great, thanks, Chris. And Eva, I'd love to kind of pose the question to you. I think particularly kind of given your experience in long-term care, are there some innovations that you've seen emerge as a result of COVID, perhaps in other parts of the healthcare system, that could address the needs of people living with Alzheimer's disease in long-term care, or even earlier in the course of their disease?
I think that most of it was already said. The role of modern technologies, which is quite innovative. It is really something that happened, and especially older people did not want to use technologies, and now suddenly it was the only possibility to connect. So they were connecting, and I think both Chris and Martin spoke about it very nicely already. I think that very important is not only the digital health or digital care, but also this, as you mentioned, Chris, already, the emotional support, consultations, but especially a meeting with family members, other people, creating groups of people, peer groups, support groups, etc., etc. So the role of modern technologies is incredible. For us, it was also the opportunity to connect more intensively with our Czech Institute of Informatics and Robotics and Cybernetics. So we are together developing some tools like speaking boxes for people with mild cognitive impairment, just to enable them training of speech, etc., etc. So I think it really moved forward, and I am very, very happy about that. But just as a joke, to speak about the other side of this thing, We also found that it is possible to have telephone consultations of physicians, or that physicians can prescribe drugs even without seeing patients. And it is the feature that I would not like to continue with very much. It is quite clear, as I see the numbers today, that or the last time, that we have the highest numbers of people with COVID in Europe, unfortunately. So unfortunately, it will continue. But I hope that after the pandemic, it will end and we will come back to our offices and we will be meeting patients not only virtually.
Yeah, and you can't replace everything during a FaceTime call, right? This is what my mother tells me when I try to call her back in Canada. So definitely some similarities there. Soeren, I'd love to hear from you in terms of what's your best bet in terms of the innovation that could have the best impact in Alzheimer's disease?
Yeah, I think I'm with Martin here. I found it very impressive how quickly we could adapt and scale diagnostic technology. I mean, this was a virus that we did not know, and within a very short time frame, we had the ability to detect it and also then detect the antibodies. And we were able to scale these tests at an amazing rate. I mean, if you imagine how many million tests are now done each day for something that we did not know until last year. So while I don't think that we will get nasal swabs for Alzheimer's anytime soon, it tells us that we are ready from a technology perspective to detect novel antigens or biomarkers and develop these tests very, very quickly for routine use. And I think that should tell us we can actually also create a similar infrastructure in which, say, a blood-based test becomes part of your annual wellness visit together with cholesterol and HbA1c.
Great, thanks, Soeren. And Maria, in your practice, were there any kind of innovations that emerged or ones that you see could have potential?
Yeah, so thank you, Lydia. So yes, COVID-19 has been definitely an accelerator of new technologies and mainly on telehealth. And I can say that it has already changed my clinical practice already. So first of all, it was very grateful for us clinicians during lockdown and even right now to be able, thanks to teleconsultations, to get to patients and caregivers. They were so happy, and it was just great. Even, of course, teleconsultation has limitations, not perfect, and especially for primary diagnosis, where I think face-to-face consultation cannot really be replaced. Maybe in the future, if we develop like more sensitive digital tools and testing for really, replace a neuropsychological assessment in a teleconsultation. But for the future, I think that maybe we could think that this is going to be, this teleconsultation, telehealth development is just transitory due to the pandemic situation, but I don't think so. As I told you already, our clinical practice is changing, and I think this experience has opened many doors and provide new possibilities to enhance follow-up care based on this telehealth, which could be complementary of the classical consultation, classical care that we already provide. So I don't think it's going to substitute, but it's going to definitely be complementary, and it's going to improve our care already. So I would think in four things about future. First, why not to develop applications in general populations? We already started in Toulouse, in France, in order to, with very simple tests, with self-assessment for general populations, 70 years and older, to assess already like very mild memory complaints. So why not to develop that and monitoring this memory loss capacity over time. Second point, as already said, like to organize this care and follow-up, like hybrid follow-up and alternating physical consultations and physical care with virtual consultations. Third point, why not use the telehealth monitoring for new treatment if we having this disease modifying treatment are coming. Why not to use telemonitoring of signs and alerts in terms of safety and efficacy, of course, during time. That would be awesome for this new treatment. And finally, why not to develop more, even there are some tools already exist, but why not to develop more perform tools addressed to caregivers in order to enhance their training, their support, and even why not to develop also monitor alert first signs of high burden or depression or even health problems in order to implement very fast preventing interventions for these caregivers. So that's how I see the present, but also the future.
Great, thanks, Maria. We've unfortunately reached the end of our panel, but I want to thank all of you, all the panelists, for a really thought-provoking discussion. I think we all recognize that there's a number of challenges with respect to, getting the healthcare systems ready for treatments and diagnostics of the future in Alzheimer's disease. But what I really loved was that there's a lot of things that are already being done, or a lot of things that can be done to ensure that readiness. And one of the messages I think that also came through was the need to kind of work together across disciplines, together with people living with Alzheimer's disease and their families, the public, companies like ours, where Martin and I work, but also with researchers and academia like Soeren, to really understand, where are those opportunities, where can we kind of quantify some of these challenges as well as solutions. So thank you very much, and I wish everyone at Alzheimer's Europe a wonderful rest of your Congress. And if you'd like to find out some more information, link to some other resources, ask some questions, I think there's a link within the Congress app where you can reach the specific Hoffmann-La Roche room. So thank you very much, and best of luck for a great Congress.